Welcome, Professor Bernd Eckert from Hamburg. You all know him from the previous session as a moderator, and we're happy to hear his talk on elective stenting or intracranial stenosis and an update on the clinical studies and the current status in Germany.
Thank you for invitation, for presentation, and I just want to use the possibility to come to very practical questions in the daily practice more than study dates. First of all, we all know that we have different pathophysiologies, and we always have to keep in mind that. The first is hemodynamic, where this is more in favor of stenting, especially embolic occlusions due to proximal occlusions. Okay, that's important. Okay, so the pathophysiology, embolic and hemodynamic was the first, embolic is the second, where you have a proximal stenosis and a distal embolic occlusion. These two cases are in favor of intracranial stenting, but you have to be aware of atherothrombotic occlusions due to occlusion of the perforators. If you treat these patients, you might have the complication of another perforator stroke. I don't know how many still know the wingspan stent. That was the first stent we ever used in intracranial stenting of stenosis, and it has the same principle like the Neurospeed Credo system, first PTA and then stenting, but we had to use it via an exchange maneuver over the guide wire, and that was a severe problem, as we saw later on. And you all know these results of the Sampras trial. And the stenting had more complications than expected, and the medical group was better than expected, though the difference was very clear and obvious. So what were the reason of the failure of the Sampras study? I repeat that again and show a few pictures. The bleeding complications was more frequent than expected. 6 were due to 7 were due to delayed spontaneous reperfusion hemorrhages, and 6 were due to wire perforations. Then we had a high group of perforator strokes, and most of them in the basilar territory. So the immediate consequence were a severe control of the blood pressure for at least 3 days. That we always have to keep in mind the distal guide wire and avoid the distal guide wire movements, and we should be very careful to treat basilar arteries. So this is an example of the guide wire perforation. This was a long time ago, an intracranial carotid stenosis. It was very hard to navigate, and you see already the navigation of the distal wire is different in these two pictures and gives you an idea of all the kind of movements we had in between, because we had to concentrate on the stenosis, of the location of the stenosis, and didn't pay that much attention to the tip of the wire. And even though we didn't see any contrast extravasation during angiography, we saw this bleeding after the procedure in the Dinette CT, which we always perform in any case, without any clinical consequences in the moment, but after 3 hours, this developed into a severe bleeding. So this is an example of the distal guide wire perforation. That was another example of a bleeding, severe intracranial basilar stenosis. Patient did well after extubation, and then 3 hours later he had a severe bleeding, and that was not due to guide wire perforation, that was spontaneous reperfusion bleeding. And you cannot always avoid that, but you can treat against it with your severe reduction of the blood pressure below 120. And this is the third main complication, basilar artery, severe stenosis, treatment, and you see before the treatment some embolic strokes, and after the treatments of the right side, the clear evidence of a perforator stroke with this parapontine infarction on the right side. So these are the main complications, were the main complications of the Sampras trial. And that was for these reasons the FDA restricted reimbursement only to patients with a severe angiographic stenosis above 70%. The patients need to be in a well state and below an MRS of 3. And the other two conditions are critical. The one is that they say they have to have at least 2 further stroke, not one further stroke, but at least 2 further strokes or even more to be treated with stenting. And the treatment must start at least 7 days after the last stroke. And TIAs should be excluded. So these were very strong conditions for the reimbursements, and for this reasons, and then we had this visit trial, which was even worse in the results compared to the medical group. But we heard about this balloon-mounted stent in the other presentations. You see the picture of that, and that was a very navigable balloon-mounted stent. I really appreciated that stent very much. It's not produced anymore, but the very advantage of that, you see here in the distal, in the proximal basilar artery, that you can control the expansion of the stent via the expansion of the balloon, and you can stop if you want to stop. So you don't need redilatation and predilatation, and this is really a good idea. And especially in this location, I still perform stenting with balloon-mounted coronary stents. You could not do it in the carotid because of the navigation is difficult, but this is still, from the technical point of view, a good procedure, a good technical procedure by balloon-mounted stent. However, the visit trial also failed, and now we had the discussion what they had in US, we had this in Germany and in every other country as well. And we had some public support for the insurance companies who didn't want to get paid a payment of the stenting anymore. And they said in this article, just 1 day before the decision of the German board, it's dangerous brain implantations of stenting. And now we have the following conditions for reimbursement, which are similar but not the same like in America. We have still an indication with recurrent stroke with dual platelet therapy, but we need to have the evidence of a new infarction. It must be a brain imaging, a MRI or CT, or a clear statement of the neurologist that the symptoms is more than a TIA. So if we document that, we will get reimbursed with intracranial stenting. And the other condition, of course, is if you have acute stroke during a thrombectomy or acute worsening. And one is the case in failed medical therapy is we have relapsing embolism. And the other case is very seldom, but it might be underdiagnosed. And these are patients who have only a pure hemodynamic symptoms. You see this patient, 79 years old, he have recurrent vertigo and fall down. He couldn't even get up. He had his same personal, his individual procedure to get up very slowly, not to get vertigo. But he had no infarction. In recurrent MRIs, he never had any infarction, no embolism. And this patient had already a recurrent basilar stenosis, and he couldn't tolerate it because he had no collateral. So this is a very rare case of a pure hemodynamic symptomatic stenosis, and you also have to document this. And this also is indicated and will get reimbursed. But it's a lot of these cases are very underdiagnosed, especially if they are only visited by neurologists. And to give you an example, what happened in these days when intracranial stenting was very out of the horizon of neurologists at that time, is a 60-year-old woman, first TIA on 13th of September. She went home after 2 hours because she had no persistent symptoms. Then she came a few days later with a real stroke, posterior simulation stroke. The diagnosis was bilateral vertebral artery occlusion. The patient recovered. He came to rehab. During the rehab, they get the next recurrent stroke. And during the rehab, he was very bad with vertigo, dysarthria, and unable to walk. He was just on ASS 100, and there was no any plan of any further diagnostic or treatment. What was the reason? He is the very severe intracranial vertebral artery stenosis, and you see below the very severe perfusion deficit, and the typical finding of bilateral infarctions in the pedula cerebralis, in the brainstem cerebralis, which is typical for hemodynamic stroke in the posterior circulation. And that was really hard to persuade the doctors at that time that this patient urgently needed stenting, and you see after the stenting the perfusion was normalized and the patient did well. So at that time, and I think it's getting a little bit better, I think a lot of patients who really need a stent are treated too late. Then we have heard about the WEAVE trial, and there's had been better results with the conditions that the FDA gave for America. And if you treat the patients at least 8 days after the last stroke, and especially if the interventionalists are very experienced, then you get a low complication rate. You see that the interventionalists who have treated more than 50 cases didn't have any complications at all, and the complications only occurred in the less well experienced. I think it's not as black and white as you see it here, but we all know that it's a very difficult, can be a very difficult intervention. So it must be done in centers. This is a very clear case. And the other reason that they get better thing is that they made the testing of the clopidogrel and they changed the medication if the patient were resistant. So if you keep attention to all these points, you get to a very low complication rate. But on the other hand, there might be patients who are treated 4 weeks or 5 or 6 weeks after the last event, and you can ask the question: do they still need the stent? Do they really still need the stent? Anyway, it's important to know these data. And what about the situations now? I don't know. I asked our registry. We have a voluntary registry in Germany where most institutes of neuroradiology give their data and at least give the name, the number of the procedures. And I couldn't tell the secretary last week to be sure that the numbers are completely right, but they give an idea. So what you see here, that the number of elective stentings in Germany are, I mean, it's a half of one center of China, as we heard today. And it's very seldom because you have to be very careful, and we have it a lot more, less frequent than in China. But what you see on the other side, that the number of the stenting, of acute procedures during stenting, that they are rising, and the people getting more and more attention to that we need stenting also in acute stroke. So these are the old devices, and this is the new device, the NeuroSpeed Credo, which we all know. That's a typical procedure, which we have seen before in an elective case, MCA stenosis, and that was a typical case of acute stenting where you have a successful thrombectomy and you see the reocclusion, a rapid reocclusion of the vessel due to an underlying stenosis, and then you perform the stenting. But I would get to attention to a few technical problems which we still have and use the possibility to address that to the company today. The first is when I see people who we don't have these procedures very frequently. So if the new doctors come and want to learn thrombectomy, they will have one stenting within 20 thrombectomies. So they will not have this procedure very often. And I always recommend to the young colleagues, always make one stent, one single shot picture, that you have a very clear vision of all the markers, and then concentrate or think about what marker you want to concentrate on, and you should always concentrate of the distal stent and the proximal stent marker, because I've seen a lot of errors in this situation. So this is one. We have to learn about the markers and be aware of which markers you want to concentrate on. So which are our problems? The balloon sizing is always difficult. If you make it too big, you might have a rupture. If you make it too small, you might have a residual stenosis. You have sometimes problems if you apply the PTA and the balloon catheter is still within a vessel which is lower than 2, especially 2 millimeters. In this case, the neurospeed will occlude the vessel, and you cannot see the result of the PTA. So if you have an underdilatation, you have to redilate, and you have to perform these exchange maneuvers with the guide wire, which you didn't want to do, or you need to re-navigate the credo, which we have shown just before by Marius Psychogios, who showed us that it's easy, but it's not always easy. So this is a problem of the technique itself, and for this reasons I would appreciate or encourage the company to think about also about a balloon mounted stent which is navigable for the cerebral vasculature. That would be a great success, a great progress. So what about the problems with the special neurospeed credo systems? We are still waiting for longer balloons, all of us. We have only 8 millimeters, we need at least 15. We sometimes have problems with the marker orientation, I said that before, and we have one seldom but sometimes severe problem that if we have just released the credo stent already, we cannot pull back the stent wire because it's stuck with, I don't know with what, but it might stuck with approximate stent markers, I think. The other problems with sufficient platelet inhibition, especially in patients with absolute arrhythmia, and the problems of recurrent stenosis are general problems. And to show you this problem with the stent, was guide, was stent wire, you see here we had a distal ICA occlusion with PTA and treated with the credo stent. I think position is fine. That was the result. But on this picture on the right side, I have no movie, but if we try to pull back the wire of the guide wire of the stent, it always we could also always see that the proximal markers of the stent moved down, so it was stuck. And then we have to talk a little bit at the wire of the stent, and you have to pull down the microcatheter or the neurospeed microcatheter just to the corner of the proximal stent, and then you might release it, but it can become a problem, and the company should be aware of this problem and improve that. At the end it was fine, but you see in the AP vision, the proximal stent markers are fine after the release of the stent, but at the end of the procedure you see that the proximal markers has moved a little bit in a direction that we don't know. Well, there was no problem with the patient, and the angiographic result was fine, but you see some deformation of the proximal stents. Then we have sometimes, this was an acute case, you see here after thrombectomy on the right side below that you have a tandem stenosis of the M2 segment, and then we made the PTA proximal and distally, and when we made the control angiography, you see that the diameter of the vessel is so small that we cannot see and we cannot control the result of our dilatation. So should we dilatate more? Is it enough? We don't want to go further because there's a very hard curve in the periphery, and we don't want to make an exchange wire, so we applied the stent, and it first looked good, but then it re-occluded. That was just, even though we put immediately the GP inhibitor, it re-occluded, and this will happen. You will always see some patients where you cannot prevent the re-occlusion, but this is not a failure of the system. This is just due to the high load of the platelet aggregation. And here at the end it was still occluded. So this was a patient of the acute study, and we were discussing about, is this a serious reverse event of a stent thrombosis, or what is it? And I would say it's a failure of recanalization. It's not a serious reverse event. It just can happen during these procedures. And 2 more pictures I show you. This is a question, which size would you choose? It's a distal carotid artery. It's already occluded due to a tight stenosis. We knew that before. and you have the vessel diameter between 3.5 and 4.2. So which balloon would you choose? 3.5, 4, 4.5? Hard to say. We don't have a TED. So 3.5 was chosen. Probably a 4.0 millimeter would have been better, but I think that's enough. You see on the left-hand side the result after dilatation, and then on the middle picture after stent procedure. So you have turned a occlusion to a middle grade stenosis, and I think this is fine. This is also a good result. You don't need to repair the vessel completely, and I still think it's better to tend to a vessel diameter of 80% of the usual of the normal vessel diameter to prevent rupture. So this should be the game: 80% of the normal vessel diameter. And this is the last case I want to show you. That was very special because he has this fenestration of the caudal basilar artery, and just behind this fenestration there is this tight stenosis. This is a result. You have some residual stenosis. I think 3.5 millimeter balloon guide was fine. The result was okay, with no reason to make another PTA. But then we have this problem where we talk about later in other presentations, this combination of absolute arrhythmia and symptomatic intracranial stenosis. How to perform the antiplatelet therapy, when to start with the NOAC, and how to perform these platelet therapies. So we had discussion with neurologists. We started first we started with aspirin and clopidogrel for 6 weeks. Then we turned to aspirin with Eliquis for 6 weeks, and after another 6 weeks, only Eliquis, the NOAC drug. But then the patient came back during the ASS Eliquis period and had new symptoms, only TIA. During angiography, we saw this stenosis or thrombus on this plaque. We don't know. We just performed tirofiban and it improved a little bit, remained stable. Now he just came back 2 weeks ago, had another symptom. So it's always hard to with drug-eluting balloon. But so far, he's doing well, just to address this problem. So our platelet therapy is, I think, like in your centers also, ASAs and clopidogrel, at least 7, better 10 days. Then we make the function tests, if it's enough working, if there is enough platelet inhibition, and if there's not enough inhibition, we change in all cases also extracranial stenting, always to ticagrelor. And in acute phase, we always apply an intracranial stenting. We always apply tirofiban intraarteriously and give an intravenous bolus and perform the loading, and always with 600 milligram of clopidogrel after we have excluded hemorrhage or big infarction. Okay, and I came to the summary. So I think this system, NeuroSpeak treater system, is very well and functions very good in the most of the cases. But still we have, and we still, this will be the case in the future, a very low number of elective stenting. So these patients should be treated in the centers and only there. We have this trial which is going on. We will hear the recent results in the next presentations, which is called the assistant trial. And for the acute PTA stenting, the numbers are increasing, and we will try it more and more in failure of thrombectomies. And we are looking ahead for the recruit trial with the Credo-Hale stent. And during all of this, we always have to keep in mind to optimize the platelet inhibition therapy and the material. Okay, thank you very much.
Thank you very much for this nice overview on intracranial stenting and your experience, especially for these complications. Any questions from the audience? Maxim?
Maybe just one short question. Thank you very much. Very, very nice cases. You said that mostly in the posterior circulation you use balloon-mounted stents. That sounds straightforward for me. Now the last case you showed, you used a self-expandable stent. Probably was very easy access. At least the vessels that you showed us were very, very straight. Do you have some kind of algorithm when you use balloon-mounted stent and when you use like the credo neurospeed system in the posterior circulation?
No, I'm honest, I don't have any, you know, and it's a good question. It depends on the mood of the day. No, not really, but if I have if distal vertebral artery stenosis, I really think about balloon-mounted stents. In the anterior circulation, no, despite excluding the petrous or say extradural carotid stenosis. Below dura, it's very nice to access, and we have a good way of balloon-mounted stent, and sometimes in basilar stenosis, but less frequent. One question.
Thank you very much for your presentation. I would like to ask, what kind of intermediate catheter would you use in case of pretty difficult anatomy? And if
We
you
always use the 6 French Navian. It's the Navian 72.
Even if you have curved anatomy,
Yeah, you need
it doesn't matter?
Yeah, but it's always an
Because
intermediate.
it's a little bit rigid, I think, the Navian.
Well, if it's you're
If
right.
you want to get close, I don't know, to the bifurcation of the carotid up there.
That's right. If you don't, we don't be successful with this 72 Navian. We change to Sophia, and we would try with Sophia 6 French. We just as the case yesterday, and sometimes you will not be able, even with the 6 French Sophia, and then we use the 5 French Sophia, because we can use with 5 French Sophia, but you don't have that much contrast agents anymore. It's not a good idea. You should better use the 6 French intermediate. So first Navian and then Sophia. That's right, yeah.
Mm-hmm. Okay, thank you.
There is one question. Your choice of guiding system when using balloon-mounted stent. Do you cross stenosis while deploying the balloon-mounted stent?
Do you cross stenosis while balloon-mounted stent?
I would guess yes, because if you don't cross the stenosis, you would place the stent in the wrong position.
Yeah. Well, I might be the question when I cross the stenosis. Probably is the question.
Sometimes we do it because it's easier. We use a lot of balloon-mounted stents. So
interesting.
In the curves, it's better if you cross the stenosis and then pull back the intermediate catheter once you have the stent in position to beat.
Okay. So you cross the stenosis with the intermediate, and then you release it on going back with the intermediate.
Yes.
Okay, but then you must be able to cross the stenosis with the intermediate, and that might be difficult, you know.
It may be difficult, but it's much easier to put the balloon-mounted stents mainly in
on the back road.
Yes, also in M1, it's very easy to when you do that. And I think it's also safer to avoid dissections of the arteries and the curves with the tip of the balloon, because the tip of the stent is generally very hard because they are coronary stents that.
Okay, that's a good point, and we actually did it last week with a covered stent where we had an dissection of the petrous carotid artery. We first covered it with a balloon, with the intermediate, and released the covered stent on the way back.
We learn from doing covered stents.
From covered, okay. I see.
One final question from my side. I think it's almost common sense that we go for a slight underdilation in intracranial stenosis. If you do that with balloon-mounted stents, do you have any concerns of having the proximal and distal stent end being in a normal vessel segment, not having enough wall opposition if you underdilate the stenosis?
Well, could be theoretically, but practically not really, because you have a very good idea where you see what you do. That's what I do